Alright, so second video of today. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at pelvic inflammatory disease, or PID. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper and let's go. So, starting with our warm-up question, which is a true or false. Pelvic inflammatory disease, PID-A, is a term used to describe infection in a pregnant woman in the first and second trimester. B, can be sexually transmitted. C, is not common in young women. D, has no bearing on fertility. You may pause the video, write down your answers. I will give you the answers at the end of the lecture. So remember, when we talk about pelvic inflammatory disease, remember, it's coming from the word pelvis, meaning it's involving those organs of the female respiratory tract, and there's some sort of inflammation. So this is pretty much inflammation of the female upper genital tract. So it's going to be involving the uterus, which is what we refer to as endometritis, the tubes, which is what we refer to as salpingitis, the ovaries, which is what we refer to as oophorytis, as well as the ligaments. Notice how cervicitis is not listed under PID. And remember that this inflammation is going to be as a result of this ascending infection that's coming from the vagina and the cervix. This clinical syndrome is not related to pregnancy or surgery, and it may complicate in other things such as a tubal ovarian abscess as well as pelvic abscesses. Now, what are the causes of PID? So the most implicated organisms are going to be things like Neisseria gonorrhea in 30% of the cases, Chlamydia trachomatis in 30% of the cases, Mycoplasma hominis in 10% of the cases. You may have other organisms such as aerobic organisms like non-hemolytic Streptococcus, Escherichia coli, Group E Streptococcus, Staphylococcus, as well as anaerobic organisms such as bacteroid species like Fragilis and Bivus or Bivius. And then you may also have Peptostreptococcus and Peptococcus, Gardnerella vaginalis as well. And rarely do you have just a single organism causing PID, so most of the times it's usually multiple organisms. But the first two causes that should come to mind are Neisseria gonorrhea and Chlamydia trachomatis. So it means even your treatment regimen, you must give them antibiotics that are going to be covering these organisms. Because the terminology doesn't really define what really PID is, even the organisms are not really well defined. Same thing with the components of the disease. So we can actually use the terminology endometritis, salpingitis, oophorytis, pelvic peritonitis, as well as tubal ovarian abscess to actually pinpoint where the infection is. Remember, cervicitis is not included in the list. Some risk factors for PID include an age less than 35 years, especially those that are less than 20 years. These are in their reproductive age, and a lot of these women are actually having sexual intercourse, which may or may not be protected. Menstruating teenagers, because remember, there is a cervical plug of mucus that prevents anything from ascending in the female genital tract. So whenever someone is menstruating, that plug is washed away and the female genital tract is quote unquote open and anything can easily descend. Even the menstrual blood can sometimes backflow and carry some of these bacteria and infect the upper part. You may have multiple sexual partners, new sexual partners, unprotected sexual intercourse, concomitant history of sexually transmitted diseases, previous history of acute pelvic inflammatory disease, nulliparity, someone who's never given birth before, areas with high prevalence of sexually transmitted diseases, as well as it may be iatrogenic risk factors such as insertion of an IUD, endometrial biopsies, uterine curettage, as well as the hysterosalpingography. Some protective factors include contraceptives, barrier methods, because of course they are blocking the sperm. Because remember that the sperm can sometimes be used as a vector by the chlamydia actually to be moving up into the upper aspects of the maternal tract. And even some of these other organisms can like hitch a ride on the spermatozoa and they can use them as vectors. So barrier methods like condoms, diaphragms with spermicides can actually prevent this. And with oral steroidal contraceptives, remember, these are going to be producing this thick mucus plug that's going to be preventing the ascent of sperms and bacterial penetration. So there is also a decrease in the duration of the menstruation, and this creates a shorter interval of bacteria to actually colonize the upper tract. Monogamy, or even having partners who have had vasectomy, is also a protective factor because you don't have sperms that can be used as vectors. Then you may have pregnancy, menopause, vaccines such as hepatitis B and the human papilloma virus vaccine. These are all protective factors against PID. Now, what exactly is happening? Remember that you have this infection that's ascending up the genital tract of this woman, and it can actually cause damage to the fallopian tube. The classical concept here is that you're going to have this gonococcus that's ascending and can actually move through this mucosal continuity and contiguity. So remember that this ascent is going to be facilitated by certain sexually transmitted vectors such as sperms and trichomonads. Then you may also have this reflux of menstrual blood, like I already explained, along with the gonococci into the fallopian tube. This can actually be used as another possibility. What I've actually realized is that with Mycoplasma hominis, this is probably due to spread across the parametrium to affect the tubes. And then, of course, with the other secondary organisms, probably they may spread through lymphatics, and rarely they may actually spread from the gut and affect the tube directly. Then most of the times you have this involvement that's going to be bilateral in the tubes, and it may be following the menses due to this loss of the genital defense. That mucus plug is no longer there because this person is having their menses. So there may be inflammation of the mucosal lining, which is often progressive, and it will end up destroying the cilia in the fallopian tube, and this can actually cause scarring in the tube, in the lumen of the tube. And this can actually form these pockets and then cause this partial obstruction, which can predispose a woman to developing ectopic pregnancies. In severe infections, actually, they may have this mucopurulent discharge, which comes out from the femoral ends of the fallopian tube, and this may actually precipitate a peritoneal infection. This can lead to scarring, it can lead to adhesion formation, and can actually even lead to pelvic strictures, not structures. Then it may also affect the ovaries, and it may form a tubo-ovarian abscess, which can actually distort the anatomy in this area. Remember that these infections usually are going to be contained by the omentum, which is like the police of the abdomen. And frequently you get these omental adhesions, and they can be seen in areas that are affected. Now, with chlamydia and gonorrhea, you may also have it involving the liver. You may have this perihepatitis that's going to be leading to adhesions between the liver and the peritoneal surface, something that we refer to as Fitzhugh-Curtis syndrome, where you have this typical Valin strings that you can actually see on laparoscopy. This is actually what they look like. You see this Valin-like strings. This is due to perihepatitis. It's due to Fitzhugh-Curtis syndrome. It's a consequence of pelvic inflammatory disease. Clinical features include abdominal pain, pelvic pain, which is usually bilateral, deep dyspareunia, which is pain on sexual intercourse. Then, of course, the onset is actually much more rapid and much more acute in a gonococcal infection, about 3 days, than in chlamydia, which can take about 5 to 7 days. You may get this mucopurulent vaginal discharge. You may get this heavy intermenstrual bleeding, which is often associated with endometritis. And there may be this post-coital bleeding. This is bleeding after sexual intercourse with a mucopurulent cervical or vaginal discharge. The patient may sometimes have systemic symptoms such as a fever, nausea, vomiting, lassitude, as well as a headache. When you do your physical examination, they may be pyrexic with a temperature greater than 38. There may be some pelvic tenderness, and when you do your vaginal examination, you may get a cervical motion tenderness. There's a special sign that's known as a chandelier sign. So if you've seen that light that usually hangs from the roof, it's known as a chandelier. So what happens is that when you're doing the vaginal examination and this person have this severe cervical motion tenderness, such that when you do the exam, it's like they almost even want to jump off the table and reach for the chandelier. So we refer to this as a chandelier sign. You may have a tender adnexal as well as a palpable pelvic mass, and you may sometimes have generalized features of sepsis and severe and systemic infection. Then tubal damage is obviously going to lead to tubal occlusion, abscesses, as well as hydrosalpinx. The diagnosis, you're going to be suspecting PID whenever you see a patient coming in with abdominal tenderness, adnexal tenderness, and cervical motion tenderness. You should suspect PID. What investigations we do want to do? Pregnancy test to, of course, rule out an ectopic pregnancy if they're a woman of reproductive age. A full blood count, which is often going to show you raised white blood cell count greater than 10,000, and you get this neutrophilia that's going to be suggesting an acute infectious process. There may sometimes be a reduction in white blood cell count. There may sometimes be neutropenia, especially in severe infections. Also, you may order for acute phase reactants, which may be raised. C-reactive protein may be raised. ESR may be raised greater than 15 millimeters per hour. You also want to get a microscopy culture and sensitivity of the discharge that's coming from the urethra, the Bartholin's gland, the cervical canal, and of course the collected pus from the fallopian tube during the laparoscopy or the laparotomy. And you want to do a gram stain for the discharge. If you find out that it's a gram-negative diplococci, this may point you towards the diagnosis. And of course, there will be a presence of abundant white blood cells on microscopy of the vaginal secretions. Culture can actually be evidenced when you actually yield Neisseria gonorrhea or chlamydia trachomatis. Sometimes a polymerase chain reaction, a PCR, can be done on the cervical discharge, especially for gonorrhea and chlamydia, and do your urine microscopy culture and sensitivity to rule out any urinary tract infections. You also want to do an ultrasound, a transvaginal ultrasound, but it's of limited value. But if you do one, you may actually show dilated and fluid-filled tubes. You may see sometimes fluid in the pouch of Douglas, or that nixal mass may actually be seen. So it's actually employed where clinical examination is difficult, or the patient is incooperative, or the patient has this acute tenderness, or maybe they are obese. You want to get an ultrasound. Laparoscopy is the gold standard for definitive diagnosis. However, in mild cases, you may not actually want to be this vigorous. Laparoscopy is going to be helping to aspirate any fluid or pus for the microbiological studies from the fallopian tube, from the ovaries, and from the pouch of Douglas. Remember, 10% of women with acute PID are going to develop this perihepatitis, which is going to be known as the Fitzhugh-Curtis syndrome, where you get these violent strains, which I showed you earlier on, these adhesions to the liver capsule. This is going to be much more suggestive of a chlamydia infection. With mild PID, the tubes are going to be edematous, there will be erythematous, there may not be any purulent exudates, and they may be mobile. With moderate PID, there is a purulent exudate from the femoral ends, and the tubes are not freely mobile. With severe PID, there is even a pyosalpinx, there is an inflammatory complex, there may sometimes be an abscess. You may sometimes perform caudocentesis, which is a procedure where you're going to be aspirating this peritoneal fluid, which is going to be obtained from the cauda sac of a female, and it's going to be done by introducing the spinal needle through the vaginal wall into the peritoneal space of the pouch of Douglas. When you do this caudocentesis, you can aspirate this peritoneal fluid, and you notice that its white cell count is going to be exceeding 30,000 cells per mil, and this is actually quite significant for PID. Bacterial cultures from the fluid actually is not so informative because of this vaginal contamination as you're entering to get this fluid sample. Differential diagnosis includes appendicitis, disturbed ectopic pregnancy, torsion of the ovarian pedicle, hemorrhage or rupture of the ovarian cyst, endometriosis, diverticulitis, as well as urinary tract infection. It's very important to distinguish three important conditions: acute salpingitis, appendicitis, and a disturbed ectopic pregnancy. Remember, amenorrhea and PV bleeding are unrelated to acute salpingitis. They are unrelated to acute appendicitis, and it's usually present in a disturbed ectopic pregnancy. Pain is going to be acute in the lower abdomen on both sides on an acute salpingitis, while in an appendicitis usually starts on the umbilicus and migrates to the right iliac fossa. With a disturbed ectopic pregnancy, it's usually this acute lower abdominal pain, but it's usually on one side. GI symptoms like nausea and vomiting are inconsistently present in acute salpingitis. They're usually present in acute appendicitis, and they're absent in a disturbed ectopic pregnancy. The patient will have a flushed face in acute salpingitis. They may have a toxic appearance in acute appendicitis, and they often are pale in a disturbed ectopic pregnancy. The tongue shows no significant changes in acute salpingitis. It may be furred in acute appendicitis, and it may be pale in a disturbed ectopic pregnancy. Pulse is raised in acute salpingitis, slightly raised in acute appendicitis, and it's not really raised in an ectopic pregnancy. And of course, temperature is going to be actually raised in an acute salpingitis as well as an acute appendicitis. It may not really be raised with a disturbed ectopic pregnancy. And often you get this tenderness on the both fornices, and a mass can be felt in acute salpingitis. In appendicitis, you get this tenderness on the right fornix and high up. Then with a disturbed ectopic pregnancy, you may actually feel a mass through one of the fornices actually extending up to the pouch of Douglas. Now, management is going to include the following principles. You want to control the infection energetically, so the partners to those patients must be treated as well empirically. You want to prevent any infection or any late complications or sequelae. You want to prevent any reinfection. So remember, patients that have a mild or moderate disease can actually be managed as an outpatient basis, and this is actually easy, especially if they have easy access to the hospital for admission if the infection becomes quite severe. If they have an intrauterine contraceptive device, if it's present, whether mild, moderate, or severe, it must be removed and they must be offered an alternative emergency contraception or other modes of contraception such as the combined pill, the oral, or the parenteral progesterones. A pregnancy test should be done and is a must in all the cases that you're suspecting PID to rule out an ectopic pregnancy. What's our admission criteria? So patients that have a coexisting pregnancy, those with severe infections such as a peritonitis, those with GI symptoms such as nausea, vomiting, with associated temperatures greater than 38, those with an adnexal mass, which is suggestive of an abscess, a tubo-ovarian abscess, or a pelvic abscess if there's generalized sepsis. If the diagnosis is uncertain, where surgical emergencies such as appendicitis cannot be ruled out, where there's poor or inadequate response to the oral medication after 48 hours, or there's poor compliance or intolerance to the oral drugs. And in patients with severe pelvic and abdominal pain requiring strong analgesics, you may also want to admit them if they're immunocompromised in the background of HIV. So we'll start with the mild to moderate infections. These ones can be managed as outpatients. So you want to advise them to have a lot of bed rest, to get some analgesia. And of course, the antibiotics is going to be a combination. So when they come in, you may give them a stat dose of ceftriaxone, 215 milligrams IM stat. Then this is combined with doxycycline, 100 milligrams orally once or twice a day, and metronidazole orally 400 milligrams twice a day or 3 times a day for 14 days. Remember that broad-spectrum antibiotic coverage with cefotaxime or cefoxitin as well as probenecid is actually indicated, as most PIDs are actually polymicrobial and are going to be caused by a range of things like gram-negatives and positive aerobes, as well as these anaerobic rods and cocci. Remember, all patients treated as an outpatient must be reevaluated after 48 hours. If there's no response, then they have to be hospitalized for IV medication. Inpatient management is going to be including bed rest. Oral feeding is going to be restricted. You're going to have a strict watch on the fluid balance. Ideally, you should give them IV fluids. Then, of course, parenteral antibiotics should be given for at least 48 hours, but this may actually be extended to 4 days depending on the response of the patient. There are 2 main regimens. So the first regimen is going to be combining ceftriaxone 2 grams IV every 6 hours for 2 to 4 days, plus oral doxycycline 100 milligrams twice a day for 14 days. The second regimen is preferred for those that have a pelvic abscess, as this is much more covering for the anaerobic organisms. So clindamycin 900 milligrams IV TDS 3 times a day, plus gentamicin 2 milligrams per kg IV as a loading dose, followed by 1.5 milligrams per kg IV as a maintenance dose 3 times a day. Alternatively, you can use cefotitan. You may also use cefoxitin. You may also combine this with doxycycline. In pregnant women, a combination of cefotaxime plus azithromycin plus metronidazole can be used. Remember, doxycycline, gentamicin, or fluoxetine should be avoided in pregnancy. Remember that these repeat smears and cultures from the discharge are going to be done after 7 days following the full course of treatment, and the tests are to be repeated the following menstrual period until you get these 3 consecutive negative tests, and when the partner is also declared as cured, then until then, the woman is cured and her sexual partners have been treated, can she then participate in sexual intercourse? Then there is a role of surgical therapy. For example, in patients with generalized peritonitis, pelvic abscesses, tubo-ovarian abscesses not responding to medication, about to give it 48 to 72 hours. And in patients with a pelvic abscess or patients not responding to therapy, a laparoscopy can be warranted. This may also exclude other causes of pain such as an appendicitis, endometriosis, or ovarian pathologies, and the usual treatment would involve the drainage of the abscess, and sometimes the affected tube or ovary may actually need to be removed. You want to counsel the patients, and remember that partner and other sexual contacts must be screened and treated. So for non-gonococcal urethritis, tetracycline 500 milligrams 4 times a day, or doxycycline 100 milligrams twice a day for 7 days. There is a risk of reinfection if you don't treat the partner, so you make sure you should treat the partner. And warn the patient that they must not practice this unsafe practices. If they have multiple sexual partners, they should at least use a barrier method to reduce the risk of further recurrences. Of course, the risk of tubal damage leading to subfertility, ectopic pregnancy, as well as chronic pelvic pain increases with more episodes of the infection. And of course, prompt and early treatment is going to reduce this risk of subfertility. They should seek early medical advice if they want to be pregnant, because there's a higher risk of them developing ectopic pregnancies. Complications may be immediate or late. Immediate complications include a tubal-variant abscess, pelvic peritonitis or generalized peritonitis, septicemia, which is producing arthritis or myocarditis. Late complications such as dyspareunia, which is pain on sexual intercourse, infertility due to the tubal damages, or as well as the tubal-variant mass, chronic pelvic inflammation, which is due to this recurrent or associated pyogenic infection. You may get formation of adhesions or hydrosalpinx or pyosalpinx or tubal-variant abscesses. Chronic pelvic pain as well as ill health. Ectopic pregnancies are by far 6 to 10 times much more common in patients that have had a history of PID than any other patient. And of course, intestinal obstruction can also be a late complication. Coming back to our warm-up question, pelvic inflammatory disease is a term used to describe infection in a pregnant woman in the first and second trimester. That's false. Can be sexually transmitted. That's true. Is not common in young women. It is, so that's false. And has no bearing on fertility. It does, so that's false. I really hope you enjoyed this lecture on pelvic inflammatory disease. If you did, consider subscribing to the channel. Hit the bell notification icon to never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.